glasses. Oh, is that the one you want?
Very cool.
Where's that one? Tissue.
What does that say? Have to do something, they disappear.
Here comes our jazzy intro, everybody.
I can't see. I have to know where your thing is.
It's on its way.
What? Here it is. Just grab it. There it is.
I'm okay now.
Just tell me which one we're in.
Good afternoon, everyone, and welcome to the Black Health Trust Weekly Program. We are so pleased you've chosen to empower yourselves today by joining us, and it's great to have our regular attendees back and those new to the program. My name is Michelle, and I'm your host for today. I hope you're all doing really well. Today, our discussion will center on our favorite topic, the COVID vaccine, and the panel will be moderated by the distinguished Dr. Randall Maxey, Chief Medical Officer of Advanced Community Medical Care Corporation and President and Founder of the Black Health Trust. Dr. Maxey will introduce his awesome co-moderator, Dr. Ivan Walks today, and our guest panel as well. Dr. Neighbor Stevens, hopefully we will talk to you later or see you next week for moderation of the program as well. So the BHT, the Black Health Trust, was founded in response to the coronavirus global pandemic and Dr. Randall Maxey's personal desire to keep his own family safe, and fortunate for us, his commitment to informing his tribe evolved into a much larger vision for our community. The purpose and mission of the Black Health Trust is to provide credible insights from our community health experts to best serve our communities of color with a coalition of leading and longstanding Black medical professionals across a diverse spectrum of disciplines, and to offer their expertise and insights into our physical and mental health during these especially challenging times. These opinions are offered to help educate and inspire you to take your health seriously and to ask questions of your own medical practitioner. That said, the disclaimer I'm going to read is as follows. Please note that the information communicated on this program is not intended or deemed to be medical or legal advice, and you should always consult your own medical or legal professional for advice and direction pertaining to your particular situation and needs. The information presented here is not advice, but rather opinions and recommendations from credible sources. Black Health Trust, its representatives, members, employees, attendees, heirs, assigns, and guest speakers and presenters assume no liability whatsoever in connection with the information presented or utilized by anybody, nor are these discussions directed to specific situations. Again, we strongly encourage all attendees of the program to consult their own legal and medical professional for conclusive guidance on how to proceed in their own personal circumstances. So that said, let's look at some housekeeping. This video conference is being recorded live, and it's on a few different public platforms like Facebook Live and YouTube. Your participation on the program is completely voluntary, and if you choose to participate today and prefer not to have your image and likeness displayed, we invite you to discontinue your visual and audio settings on your personal device. That said, all participants will be muted by our Zoom technician initially, and we ask that you remain muted until the host or moderator asks you to contribute in order to minimize the distraction of background noise, and so we can give 100% attention to our speakers. So if you could just check and make sure your device is on mute until called to speak upon, that would be greatly appreciated. With regards to the chat room, if you have questions, we hope you do, you can enter them into the chat room, but please limit your questions to 2 questions per topic being addressed, and please do not use the forum to advertise or promote your own personal products. We'll get to as many questions as we can. And so I'd like to thank the Black Health Trust Steering Committee, the Executive Board, our virtual administrative assistant, our media production and Zoom technician, BHT supporters, and all the people behind the scenes for their time and efforts that make this program possible. We are in this together. If this programming has been valuable and interesting to you, please visit the website to learn more about our programming and how you can support Black Health Trust so we can continue bringing our community outstanding content. Visit blackhealthtrust.org, or you can email social@blackhealthtrust.org. If you do send an email to social@blackhealthtrust.org, please include your first and last name so that you can be added to the BHT mailing list. If you don't want to be included in the mailing list, please just indicate that in your email. Thank you so much. So let's welcome now all of our distinguished physicians and special guests. We thank you for sharing your valuable time, as always, your information and educated insights with us today, and your participation and support help empower our communities of color. And this is an oh so critical time for our future well-being as a people. Black is beautiful and knowledge is power. So welcome again, everyone, to the Black Health Trust Weekly Program. This is our community. This is our time to take care of our health. Grab your coffee, tea, get comfortable, lean in, and Dr. Maxey, please do us the honor of beginning today's program.
Thank you so much, Michelle. We appreciate your wonderful introductions and ability to keep us on track. And we thank you for joining us each and every week. I'm Randall Maxey. I'm a kidney doctor located in sunny Southern California. I know some of you are experiencing extreme weather in the South and the Midwest, but out here it's about 75 degrees. Eat your heart out. We have planned today a program that will feature interaction, and we want to answer many of the questions that we all have regarding COVID, regarding health disparities, but especially regarding vaccines around COVID-19. So we've got a panel of physicians. In addition, we're joined by members of our medical advisory, and we're gonna maybe ask select members of that group to address or interact with our discussants. And I'm going to invite one of my mentors, one of the people that I admire most in the medical field, not because I necessarily need mental help, but maybe I do. But I'd like to introduce my distinguished co-moderator and former commissioner and director of health for the District of Columbia, psychiatric graduate of UCLA, and presidential advisor under George Bush, advisor to the Secretary of Health, and many other things, Dr. Ivan Walks. Hello, sir.
Good afternoon, Dr. Maxey, and thank you for such a warm introduction. Well, I think if you're just a kidney doctor, is that what you said? Is that how you try to introduce yourself?
Yeah, I'm kidding.
Dr. Randall Maxey, if you're just a kidney doctor, then the brain is just another part of the body. I am so honored to have known you for such a long time and to just be amazed by all of your accomplishments over the many, many decades that you've served our country, even though you're such a man. Wearing those cool glasses today. So we would just continue to just enjoy, Dr. Maxey, all that you bring to us, and the Black Health Trust is just a small part of that. So we are excited. I count my Sundays by two things, church and the Black Health Trust. So I'm really excited to be here this afternoon. And even though I'm on the East Coast, it's officially afternoon on the West Coast, right?
That's true.
Yes, sir.
Can I ask a question that we haven't done before, Dr. Walks? Would it be possible that we can invite our virtual assistant just to read for us the names of the individuals on our medical advisory board? Some of those names, they're on with us almost every week, and we don't necessarily always mention their names. Would that be something good? Could we ask Yakini to do that if she has that list handy? Yakini, are you available?
I believe she's coming through momentarily. I saw her unmute.
Okay.
Can you hear me now?
Yes.
Sure, give me just one moment and I'll be happy to read those names for you.
These are truly some respected individuals who devoted their time and given us all kind of information. And we have wonderful and spirited discussions on Wednesday night with this group.
Okay, so some of the members of our medical advisory board are Dr. Helen Davis, Dr. Jordan Wilbert, Dr. Keith Norris, Dr. Walter Faggett, Dr. Michelle Clark, Dr. Ken Steiner, Dr. Barbara Nabert Stevens, Dr. Ron Bailey, Dr. Carolyn Towler, Dr. Cecil Motley, Dr. Richard Williams, Dr. Lamont Gibson, Dr. Jesse Sherrod, Dr. Lisa Kervendaz, Dr. Michael Carter, Dr. Ann Stavrin, Dr. Randy Hopkins, Dr. Georges Benjamin, Dr. Berthad Vladimir, Dr. Moro Salafu, Dr. Edith Mitchell, Dr. Jordan Despani, Dr. Rhonda Moore Johnson, Dr. Natalie Daly Garns, Dr. Monique Hedman Maxey, Dr. Rachel Villanueva, Dr. Randall Morgan, Dr. William Goffney, Dr. Kimara Jones, Dr. Randall Maxey, Dr. Ivan Walks, Dr. Napoleon Higgins, Dr. Virginia Kane, Dr. Leon McDougall, Dr. Oliver Brooks, Dr. Suzanne Cutter, Dr. Gerald Devon, and Dr. William Faulkner.
Thank you so much. Dr. Walks, go ahead.
Certainly sounds like you're playing with an all-star team, Dr. Maxey. I'm gonna bet on your team. Happy to be a part of it. As we usually start every Sunday, we want to start with the COVID-19 tracker. So if we can put that up, and I'm happy to go through the data which we pulled from the CDC. As of 8 p.m. last night on March 27th, we had total US cases of 29,976,179. Total new daily cases, 71,593. Total US deaths, wow, it's never easy to read this number. Total US deaths, 545,273. Total US daily deaths, 1,283. Total vaccine doses administered, 91,707,729. All that data as of 8 p.m. last night. And the next slide is the one that looks at race and ethnicity of people administered with at least who have had at least one dose administered. And this shows us that if you look at the race and ethnicity on one side and the percent among persons along the bottom, we see that Black non-Hispanics are still lagging behind in the amount of vaccine per population that we should have. And I think I make this comment a lot. When we're having a conversation about whether we should take the vaccine, that's not hesitancy. Hesitancy is when you bring it to my community and offer it to me, and I say, well, I don't want to take it right now. That's hesitancy. So I think that we are still a long way away from equitable availability and equitable offering of the vaccine in many of our communities. And these numbers show that we are still behind where we should be in terms of having our community vaccinated. Okay, so Dr. Maxey, did you want to let us know who is going to be joining us today?
Well, I'm going to give you that honor
Okay,
to
I will do
introduce
that.
our two of our favorite people that are go-to, and I appreciate them being with us. Go ahead, Dr. Walks.
I want to give another quick shout out to the amazing Dr. Nabert Stevens, who is making her way through some bad weather, and we're hoping to have her join us. One of my favorite people to introduce is Dr. Jordan Despani. I just call him Smart Guy. Dr.
Is he that whiz kid guy?
Hey, look, I get smarter every time I just look at his picture. Dr. Jordan Despani is an entrepreneur and medical communicator driven by the challenge of addressing complex problems through biotechnology. He obtained his BS in biology from Louisiana State University, where he conducted research on coronaviruses. Dr. Despani investigated the molecular biology of cystic fibrosis at Johns Hopkins Hospital. He later earned a pharmaceutical sciences PhD at the University of Southern California for his dissertation work developing chemotherapy drug carriers to combat triple-negative breast cancer, an aggressive disease primarily affecting young Black women. Also staying with the young and brilliant, we go with Dr. Janine Daly Garnes, MD, MPH, MS. Dr. Garnes graduated from Princeton University with a degree in molecular biology, earned her medical degree from Harvard Medical School. She trained in internal medicine, pediatrics, and adult and pediatric infectious diseases at Baylor College of Medicine. Currently, she practices infectious diseases in Houston, Texas. We are excited and honored to have Dr. Despani and Dr. Daly Garnes with us leading our discussion today as we all gather information on what we know and what we want to know. And I think this is like high school. There's going to be a quiz or a pop quiz at the end.
I think so. And I want to say this about Dr. Daly Garnes. Her mom was a good friend of mine. We sat for 6 years together at the board of trustees of the NMA. So I got a daily report on Dr. Garnes' whole medical education. And even though I haven't had the honor to meet her in person, I know everything about her days at Princeton and Harvard and every place else, Dr. Garnes. So I'm your fan.
And I just got a text, Dr. Maxey, from Dr. Neighbor Stevens, who is on by phone and wants to make sure that we know she's listening. So we can't get in any trouble because she's paying attention.
Hello, Dr. Neighbor Stevens. Be safe. Okay. Go ahead, Dr. Walks. We're ready to roll.
We're ready to roll. So are we going to, Michelle, are we going to start with our first poll?
We sure can. If you want to pop that up, Simon. Okay, so we're going to do a series of questions, not too long, but the first is, and we want you to answer these in your profiles. Number 1, true or false? Masks cause a buildup of carbon dioxide, CO2, in your body. True or false? And the second question is, cloth masks do not protect against the spread of COVID-19 infection. True or false? And we'll give you a minute to enter your answers on those. And Simon will collect that data. Number 1 again was masks cause a buildup of carbon dioxide in your body. True or false? And number 2 was cloth masks do not protect against the spread of COVID-19 infection. True or false? Looks like we have some majorities there. Looking good. Okay. Dr. Walks, can you see the results there?
I cannot see the results.
Well, number 1, we have the question was, masks cause a buildup of carbon dioxide in your body, true or false? At 87%, we have everyone responded false. There was 13% responded true. And I think that we're going to share results now. Can everyone see that? Results? Thumbs up? Great. All right, Dr. Walks, you can take it on over from there.
Okay, great. I can see. So we have, so question number 1 is false. Carbon dioxide does not cause a buildup of carbon dioxide in your body. Things that tend to cause bad carbon dioxide buildup in your body, I think they tend to kill you. And we haven't had anybody die from wearing masks. So no, that's, and then the other one with respect to cloth masks not protecting us, I'm going to have one of our experts handle that one. I remember being in school and always reading too much into the question. Are we talking about a 1-layer mask, a 2-layer mask? And when we're talking about protecting us from infection, are we talking about total protection, 100%? Are we talking about 90%? So maybe Dr. Despani or Dr. Daly Garnes, you all can help me from reading too much into the question and help us understand, what do we mean when we say that cloth masks may not protect us as well as we need them to? Are we talking only about single layer masks? Please help us with that.
Yeah, I mean, I would probably advise that having any type of like barrier between your respiratory and even your nostrils, as well as something, like a particle and whatnot, would definitely, be beneficial. But there are different gradations to that. So a virus is typically at the nanoscale. Nanoscale means 1 × 10⁻⁹. So basically, that's exceedingly small. In fact, that's the science of the small, if you will. But then the type of masks that truly offer like 100% protection are basically N95 masks. So it literally states on the I guess on the the name itself that N95, that protecting against 95% of all particulate matter and whatnot. But a cloth mask still offers some variant of some manner of protection.
I would just add to that. I don't think you're reading too much into the question, Dr. Watts, because I think it does matter. Definitely, I agree with Dr. Despani that something's better than nothing. There were some early studies that were done last spring that the net gaiters, which are a single layer and kind of polyesterish often, that they may actually almost be worse because they may actually make what would normally be a respiratory droplet size aerosol size. So that would be one caution. If you want to wear the net gaiters, that you should probably still wear something else. In terms of cloth masks, the preference is for it to have at least 2 layers. Hospital grade masks are going to protect better than just regular homemade cloth masks. And that's where some of this conversation about maybe wearing 2 cloth masks when you're out in public may give you protection that's more similar to what you're getting with a hospital grade regular mask. And then definitely the N95 is your, most effective protection. But you have to keep in mind that to get that top protection from an N95, it needs to be fit tested. That means that you have to have the right N95 for your face. There are different sizes of N95s, and there are also different manufacturers. And some of the manufacturers' masks fit differently on different people and provide that secure seal for some people and not for others. The other thing to keep in mind, especially for our community, is that facial hair can affect that seal. So for persons who have facial hair, you may not be getting that same seal with the N95. And so that's something else to take into account.
So I got a text from Dr. Naybrit Stevens. CDC recommended cloth masks for public use. I think that it's important that we all are on the same page that folks need to wear a mask that covers your nose and your mouth. And I think that it's really that simple at the bottom line. We need to wear something that covers our, and then remember what it's for. Sure, it can be a fashion statement. I've seen some great masks with all kinds of great things across the front, and it's wonderful. If you put that on over your plain multi-layer mask that doesn't have anything fancy on it, no problem with that. I think the issue for us is that we need to recognize why we're wearing a mask. As Dr. Despani said, we're trying to protect against things we can't even see. And so that we can't even nearly begin to see, very, very tiny things. And so the better covered we are, the better we protect ourselves and the better we protect others. So
let me raise another question to Dr. Despani and Dr. Garnes and others. When I come home from work and I've been wearing a mask all day or 2 masks all day, should I throw it away? Should I put it in the microwave? Should I put it in the oven? Should I get a new mask? What can we do for cleanliness with our masking strategy?
I'd say one thing that I heard that resonated with me is to treat your mask like you treat your underwear, which hopefully means that you're washing it frequently and changing it every day.
That's good.
And
That
then-
is good.
Yeah, and I'll add on to that. Yeah, like so I have, for instance, here like a regular cloth mask and whatnot. And like for this, you can envision wearing that maybe I'd say 1 to 3 times. I don't go out that much anyway. So, but obviously every time you use it, you have to make sure that you're not, say, touching the like this blue portion and whatnot, because that's actually what is contacting these toxins or pathogens and whatnot. And really, whenever you get a mask like this, they come typically in like a 10-pack, 20-pack, 30-pack, 40, 50-pack. So, like really, you can treat this as a one and done if you really want to. And then there are actual N95 masks, as I don't know if you can see this here, but, basically it actually goes over the, you would put the bands over the head and then get that snug fit, like Dr. Daly Garnes was discussing. And for this, obviously, you probably, being that it's of a sturdy build, you do probably want to maintain the cleanliness and whatnot. And you can, obviously, if you don't want to bake this, you can't bake this, but you definitely want to like disinfect and then leave out, like, say, maybe in a sunlit area to have the UV radiation destroyed. And like for me, sometimes when I go out, like I make sure when I'm taking off the N95 mask, again, I only do that whenever I'm very worried about when I go out. I then when I take off, I make sure to always grip each side, and then I place down such that I'm not touching the this outer edge. And then afterwards, I actually use a disinfectant spray, which contains a lot of weird things like phenol and whatnot, because one of the interesting things about SARS coronavirus 2 is that because it's a coronavirus, it actually has a lipid membrane, and that lipid membrane actually means that it's more likely to fall apart once that lipid membrane is destroyed. There are other viruses like adenovirus that actually don't have that lipid membrane, so they're more sturdy and impossible to destroy. Not impossible to destroy, but more difficult to destroy. So again, you want to leverage like some of these chemicals and whatnot to actually like break down and degrade the SARS coronavirus 2 variant. So yeah, so definitely like after using an N95 mask, what you'll want to do is like remove the mask such that you're not touching that outer portion, spray it with like a disinfectant and let it sit for some time, and then you probably want to be able to then use it again. But again, I don't advise like using this again and again and again and again. So you want to have like a multitude of masks.
Now, if you are forced, we gave some earlier advice that you can put a cloth mask in a standard oven at 150 degrees Fahrenheit for 30 minutes. And you can do that for 2 or 3 times if you're forced to do that. You can put that same mask for 60 seconds on high in a microwave, provided it doesn't have that metal thing in the nasal area. And then cloth mask can also be in a regular washing machine for a hot cycle. And you can do that a number of times. So that's good. Thank you so much. Dr. Ivan?
So one other personal plea, when you wear your mask, the reason it has that little metal part is so you can pinch it down over your nose. People just put the mask on and every time they say something, it slides off of their nose. And I hate having to say to someone, could you pull your mask up? So just do us all a favor and just use that metal piece and pinch it down. That's what it's there for, is to help it make a better seal and to keep it from just sliding off the minute you begin to talk. Personal plea, please do that.
And
Okay.
one other thing that I've noticed, I do much better in my mask after I clean my mouth with Listerine or something.
The backlash is real, yeah. There was one quick other question. Dr. Despani, maybe you can explain the difference. How do the K95 masks differ from the N95 masks?
Yeah, so the KN95 mask are actually like those are approved by the CFDA, the Chinese Food and Drug Administration, and some of those have been tested here in the United States and like have been found to be able to have like efficacy in blocking out 95% of the particulate matter that comes the way of the mask. So those are approved, and yeah, apparently they can block out about 95% of 0.3 micron particles, which, all you have to do is move the 0.3 micron, like because micron is 1 times 10 to the negative 6, all you have to do is move the decimal place 3 over. So it can block out nanoparticles that are up to 300 nanometers.
Thank you, Dr.
So,
Desvani.
yeah.
Dr. Walks?
Okay, so why don't we plan to go ahead and move on to our next set of questions?
Okay, so here's our next set of questions regarding post-vaccination. So number 1, you no longer have to practice safe distancing in public spaces, true or false? You no longer have to practice safe distancing in public spaces, true or false? Number 2, you cannot catch COVID-19 after you receive your first dose of either the Pfizer or Moderna vaccine, true or false? And number 3, you no longer can infect anyone with COVID-19 after vaccination, true or false? Number 4, you no longer need to wear a mask, true or false? Number 5, you can't catch the flu after receiving COVID-19 vaccine, true or false? We'll give everyone a few minutes to, a minute or two to complete that. And these all have to do with post-vaccination.
We should have some countdown music during that.
Simon, you have any jazzy countdown music? We had Patrice Rushen on last week, no?
We sure did.
I'm sorry I missed
Are we
that.
authorized to play her music?
Yes.
Okay.
Have you got it on cue, Dr. Walks?
I do not. I wish I did. But as a tiny commercial, as our website up and running, folks will be able to go back and listen to the previous program. So they can go back to Patrice Rushen, they can go back to Brenda Lee Ager, they can go back to all of the wonderful scientific information, of which the music is a part. We really learned a lot about how therapeutic music can be and how music can be used in a therapeutic environment. So just wonderful.
That's kind of jazzy, kind of nice, huh?
It kind of reminds me that that's the name of the song.
Ba-dum-bum.
Very good.
All right.
I'd like to know how the answers came out.
Are we ready?
So
Okay, Dr. Walks, can you see the responses?
I can see the responses.
Okay.
So the first question, you no longer have to practice safe distancing in public spaces. Everybody recognized that that's false. Yay. You cannot catch COVID-19 after you receive your first dose of either the Pfizer or Moderna vaccine. Again, everybody recognized that that was false. You no longer can infect anyone with COVID-19 after vaccination. I want us to spend a little bit of time and talk about that one. So I want us to really come back to that one. The next question, the question is, you no longer need to wear a mask after you're vaccinated. And everybody got that correct in that that is false. You do need to still continue wearing your mask. And then the last question, this is one of those easy questions. I like these. You can't catch the flu after receiving COVID-19 vaccine. I don't think the COVID-19 vaccine has anything to do with the flu. So everybody said that that was false. But let's go back to the question of you no longer can infect anyone with COVID-19 after vaccination. And we had a couple of folks say that that is true. And people have asked me that question, and my answer to this point has been, well, we're not really 100% sure about that answer at this point. Am I using old science, Dr. Daly Garnes?
Okay. So I would say, again, we've talked about this previously. The studies were designed to get FDA approval as soon as possible, which meant that they were designed to show a decrease or effectiveness in preventing disease related to SARS coronavirus 2, or preventing symptoms related to COVID. And so that's, all of the efficacy that's being reported, like that's what those numbers are talking about. To answer the question as to whether you can give someone COVID after you have been vaccinated, we don't know yet. But, given the decrease in transmission that we've seen in a lot of the long-term care facilities where a lot of people have been vaccinated, we're starting to see evidence that may suggest that. Now, again, unless you're doing testing on everyone, whether they have symptoms or not, you're not going to know, because it could be that people are still passing COVID, they're just not showing symptoms anymore. And those studies, to my knowledge, have not been disseminated or published yet.
Dr. Despani?
I second everything Dr. Daly Garnes, detailed, in that we are finding studies that indicate that the vaccine may be able to halt transmission rates and cycles, but again, it's still for a vaccine that only has emergency use authorization, hasn't even been FDA approved. So, once it actually is FDA approved, and then we can conduct phase 4 studies and have a more robust data set to make that assumption.
So let me ask if somebody has had the vaccine and they've had one of the first doses of either Pfizer or Moderna, what is their level of what is their level of protection at that point in time?
So just to clarify, the level of protection after a.
All right, yeah. What is their level of protection at that time in between the doses? Do we encourage people to make sure they get that second dose? Are they adequately protected after the first dose? Is there any problem in that in-between situation? Should I take my first dose and think I'm good?
Yeah, so this is, Dr. Daly Garnes, I actually, I want to be a gentleman, so ladies first.
I certainly expect you to chime in too. The initial studies, at least for the mRNA vaccines, the 2 mRNA vaccines for which we have emergency use authorization up to this point, is that after a first dose, that we have about 50th percentage, but we definitely have seen, I've talked to a lot of people that have gotten infected between that first and second dose. And we definitely are seeing, the numbers that everybody was raving about in terms of preventing transmission or development of symptoms, in terms of preventing hospitalization and the development of severe COVID. All of those studies for the mRNA vaccines were done after 2 doses. So, everybody, in order for us to optimize, to really bring the numbers down, to get closer to getting to our new normal that is more functional than our current normal, everybody's recommending that you receive 2 doses of those vaccines. Now, obviously, we've talked about, we now have emergency use authorization for the Janssen or Johnson & Johnson vaccine, which, has been authorized for a single dose. And in that case, we're getting, the numbers are not the same in terms of the development of any symptoms of disease, but we're still seeing very good effectiveness in terms of prevention of the development of severe COVID and hospitalization and effects on mortality. So, yeah, it's okay to get, at least as of right now, everything's in flux. it's okay to get 1 dose of that vaccine, but we really are continuing to recommend that you get the 2 doses of the mRNA vaccines, specifically the Pfizer or the Moderna vaccines.
Yeah, and I was also like going through my notes that I sent out to a buddy in the legal space that he actually had asked some questions, and I was going through a New England Journal of Medicine paper focused on efficacy data points, and they stated that the vaccine efficacy for the Pfizer vaccine was 82.0% after dose 1, but it actually declined. It declined to 52.4% after that first dose, but prior to the second dose. And at the time, I was trying to figure out the time interval for that first dose. But obviously, this wouldn't be very entertaining if I was going through my messages to other people. So suffice it to say that the gist of this is, as Dr. Daly-Garnes was saying, that unless it's the J&J vaccine, then you want to get both doses. And the whole thing is that all you're doing is you're just priming your body to recognize who the intruder is, but you need that second dose for your B cells and eventually your T cells to be like, okay, like I now know what to do. I'm a sentinel. I'll go on a seek and destroy mission, and that'll probably last for about a year to 2 years based off of what we know concerning how long immunity lasts for SARS coronavirus 1 and Middle Eastern respiratory coronavirus. So.
One other thing that I would point out is that for persons, which I think is particularly relevant to our community, who are immunocompromised for various reasons, we're starting to get some early data in those populations. And, the thing is, we don't have a good measure for how we know that somebody's protected after they get the vaccine. We talk about antibody tests, and I'm sure we'll get to that at some point in the future, but, antibodies are not perfect. What we are seeing is that among some of these immunocompromised patients, so patients with autoimmune disease that are on active treatment, patients that are transplant patients on active immunosuppression, that they're not getting the same degree of antibody development after that first dose. And so it's even more important for those patients to get the 2 doses.
So I have an ethical question and also an informational question. The ethical question, I got word yesterday that the mother of a friend of mine who's 103 years old was forced to take the vaccine against her will. That's one question. What do we do in that situation? What are your thoughts on that? But the more relevant question is, are there any reported cases of mortality or significant morbidity post-vaccination, either with Moderna, Pfizer, or J&J?
Yeah, I guess so. So I do want to parlay off of one comment that Dr. Daly-Garnes made concerning the immunocompromised patients before I jump into the answering those questions. And basically, at the research level, we have actually found that a lot of the random point mutations that came about that have allowed variants to, proliferate out of all control actually did arise in immunocompromised patients. That's basically where the data is leading. So have to be very assiduous about ensuring that immunocompromised people are protected. Now, regarding, my thoughts, because again, now we're getting into bioethics and whatnot, I definitely think that there's no grounds whatsoever for if somebody doesn't want to get a vaccine, you can't force them to get a vaccine. I mean, that's shades obviously it's not a one-to-one parallel, but that really is similar to how, the Tuskegee, syphilis experiment involved people were expecting a treatment, and instead, they were being used as guinea pigs. Or even you want to look at Henrietta Lacks, and that, her cells were taken to create the HeLa cell line without her knowledge. And, the whole thing is that it's supposed to be trying to treat a woman for cervical cancer. So again, at the end of the day, you have to really do what's in the best interest of the patient, and even if it's ethical concerns. For instance, look at the case with Jehovah's Witnesses. They have a religious prescription on taking blood, even blood transfusions, and you just have to honor that. So that solves that question. And, and then obviously I know Dr. Daly Garnes will bring the clinical perspective, obviously, buttressed by the Hippocratic Oath. And then the second question that you had, Dr. Maxey.
Have there been any reports of deaths or sickness, meaning morbidity significant, related directly to having the vaccine?
Yeah, so this is something that I actually have chatted with Dr. Carter, Michael Carter, about, and they're actually, I have seen like small cases that have actually been reported on by the New York Times where people do develop this thrombocytopenic purpura. So yeah, I mean, there are cases where people will develop like a, random autoimmune reaction. I mean, I speak as somebody who actually did develop a form of purpura. In my case, I developed the Henoch-Schönlein purpura. And basically, to use something that Dr. Michael Carter had mentioned, basically you're looking at a patient as being like a bucket, like multiple buckets of the different aspects of their different, organ systems and whatnot. And for somebody who has pre-existing conditions and whatnot that you don't, either you don't know about a priori or you do know about and still think that need to vaccinate them, you have to really also factor in like you might overflow their bucket too much and then they might develop an immune response and whatnot. But again, we don't really have a firm handle on immunology to speak of just as a species. So it's tough to know a priori, who will end up developing these random deleterious reactions.
Dr. Garnes?
So to go to the initial bioethics question, the parallel that I'd like to draw is that, we found there's a lot of information that shows that when you vaccinate healthcare workers in a hospital, that you significantly against influenza, that you see a significant decrease in influenza transmission to the patients within that hospital. And for that reason, a lot of institutions have, mandated that their employees either get vaccinated or have an official opt-out, with a medical excuse for a reason not to be vaccinated. So in my institution where I practice is one of those places, but they have not done that for the COVID vaccine because we're functioning under an emergency use authorization. And so that's why I'd say, like, especially in that situation where we don't even have an approved vaccine, that it's really not reasonable to force someone to get a vaccine that has not gone through the full vetting process that we normally require for our vaccines for approval. To speak to the second question, I don't know that I really have much to add. Yes, there have been deaths associated, as with any medication or any foreign substance that we're putting in our bodies, there are always risks associated. And, we are, I remain a strong proponent and advocate for this vaccine. But when I have the conversation with my patients, I have to acknowledge that we don't have all of the knowledge that we normally would have related to a vaccine. And the primary reason for that is just the fact that we're functioning in this very severe, deadly pandemic. And to wait the amount of time that it would take to have all of that information, we just talked about, we have over 500,000 tests just in our country. We don't have time for that. And so, there's a push and pull that we have to take into account here.
Okay, thank you so much. Dr. Walks?
So I see Dr. Jordan is waving at us, Dr. Maxey. And I know you don't want to get in trouble with Dr. Jordan. So
Definitely not.
Can we unmute Dr. Jordan for just a minute?
Dr. Jordan interviewed me for my internship in Boston, so I got to give him respect.
Must have been
Hello,
about
Dr.
2 years old when he did that.
And I was 14 and he was 12. So to answer your first question, and Dr. Maxey again can verify, I developed a cerebritis after my vaccine. I wasn't aware of it really. In fact, I was on the program and Randa called me afterwards and said, "What's wrong with you?" And I was out of my head. And when I left the clinic, that Thursday night at 3:30, my godson called me at 7:30 saying, "Where are you?" And I had been driving around the freeway, just making a square, up to the 10, west to the 405, all the way around to the 605, back up to the 10, over and over and over. Wasn't in any pain or anything. I was just doing it. He had to guide me home. So yes, you can have some side effects. And just as Dr. Bailey said, I still am a big proponent of the vaccine, though I think we have to make sure people are aware they can have things. My godmother is 102. We wouldn't want to give her the vaccine, though we make sure all the people who come in contact with her have had the vaccine. She's 102. So I wouldn't force anyone 103 to have it, but I would try to get everybody around her to have it, so nothing happens to her. And the last thing that Dr. Walk said earlier, I think we've forgotten, when we had the polio vaccine, when we had the smallpox vaccine, we didn't get it first. They vaccinated us in school, but they vaccinated the white kids first. Then we got vaccinated. That's been a routine thing until probably maybe the 90s. So, but I think we have to make sure that we support this one. I have a problem with so many of our patients not wanting to take it. And one thing we have found, because we have tested all of our OASIS patients, and all OASIS patients by definition are HIV positive. We found 13% had antibodies to the vaccine. Only 4 were aware that they had been exposed. But when we repeated the antibody test in 6 months, half of them had lost it. So, we need to enforce them getting it early. So that one of the things that the vaccination does, it gives you enough exposure to this virus that it allows the body to make a stronger immune system than just getting it on your own. And third, I don't know if the HIV meds are playing any role, because I found it quite interesting that we had so many patients testing positive and they had not been sick. So thank you. And I'm glad you saw my hand being raised.
Thank you.
Yeah, Dr. Jordan, I've learned over the years that anyone Dr. Maxey's afraid of, I'm afraid of too. So how about that? So
Let me ask Dr. Garnes a follow-up question, if you don't mind. She mentioned patients with renal transplants and the vaccine. I want you to just speak about that a minute, and some of the other immune diseases and autoimmune diseases like lupus. Can you just review that once more, what your thoughts were on that?
So the study that came out very recently, they basically performed, and these are ongoing studies. I know that some of the nephrologists here are participating as well, where they're checking antibody results after vaccination in their transplant patients. And specifically what they saw is that after the first dose in these patients, they were seeing rates of like 17% of conversion to producing antibodies. And the patients that were least likely to have antibody conversion were patients that were on antimetabolites such as mycophenolate, and so some of those antimetabolite immunosuppressants, and then also patients that were on 10 milligrams or more of prednisone daily. So those were the patients that really seemed to not have as adequate antibody responses after the first dose. That study was published only after the first dose, so we don't know what those numbers look like after the second dose. There was another call that I was on yesterday, and there was a very interesting talk, and I spoke with Dr. Maxey about this. I think we should have somebody speak on this in more depth at some point, just because we do have so much autoimmune disease in our community. But one of the things I've really been waiting for are the data related to, the effects of COVID in patients with autoimmune disease. and now waiting for the information about how the vaccine works in that population. And so there have been some very preliminary data that were discussed, but have not been reviewed or published or anything at this point, that they are seeing decreased antibody responses in patients with autoimmune disease on active immunosuppression. Steroid doses, again, rituximab is one of the big things that they're seeing, particularly in patients with disease, that patients who have gotten rituximab are having worse COVID disease. And you can imagine, because rituximab knocks out B cells, that those patients are also potentially at increased risk for not responding to the vaccine. But they are seeing antibody responses in patients with autoimmune disease that are on immunosuppression. They're just decreased compared to the general population.
Well, thank you. And the question we have with those renal patients or other organ transplant patients, we try to keep the organs in by knocking the immune system down. But with COVID and vaccines, we're trying to raise the immune system. So there's a contradistinction there.
Yeah.
Dr. Helen Davis, one of our advisory members, is tasked with finding, putting together a program with rheumatologists, which could answer the question of autoimmune diseases. So look forward to that program coming up. Thanks so much. Dr. Walsh, back to you.
Thank you, Dr. Maxey. So I want to be clear about something. We've talked a little bit about folks not being forced to take the vaccine, which I completely 100% agree with. We've talked about Dr. Jordan's experience with having temporary challenges after the vaccine. And I think both Dr. Despani and Dr. DeLegards have both been very clear that, and Dr. Jordan as well, Dr. Maxey as well, that the vaccine is still being recommended. Folks are still being urged to take whichever vaccine they bring to your neighborhood. There's a lot we still don't know. And at the same time, what we do know is that COVID-19 will kill you. And even if it doesn't kill you, it can have long-lasting impacts that are unpleasant. And so we are very, is that a fair way to encapsulate it? Yes, we're all going to have some story that someone tells us or some experience with someone that we know that makes it a little bit more than just, oh, my arm was just sore for a day and oh, I felt okay. Everyone doesn't have that story. But at the end of the day, it sounds like we're all still recommending that. Dr. DeLegards, is that a fair encapsulation?
I would agree. I mean, again, we know every vaccine has risks. Every vaccine has a population of patients for which the vaccine is not recommended. But if you don't fall into those categories, particularly in this case, as contagious as this is, as deadly as this is, and then, as you mentioned, the people who they don't die, in some cases, they have very mild initial courses, and then there's progression over time afterwards, the long haul syndrome, people have had to stop working. I had a patient the other day that had to retire prematurely. There are a lot of impacts, economic, social, functional impacts that getting infected with COVID can have. And you never know if you're going to be one of these people that it's like, a little thing and you move on, or if you're going to have one of these more severe outcomes. And, we know that the likelihood of those things happening with the vaccine is much, much lower than the likelihood of those things happening if you get the infection.
And I think the key point that you bring up that I'm very sensitive to, I have a number of patients that have developed a so-called long haul syndrome. And we're going to have a program on that in the future. And that potentially has its own devastating effects. So I definitely remain a fan of being vaccinated as soon as possible, because there are some unknown long-term effects that occur in young children and adolescents as well as us older people. We should go on with the program, Dr. Walsh.
Yes, sir. So let's get to our general questions poll.
Okay, under the general questions poll, we're asking, true or false, is it recommended that pregnant and breastfeeding women take COVID-19 vaccine? True or false? And number 2, COVID-19 testing is no longer necessary or needed. True or false? Number 3, there are 3 licensed COVID vaccines in the US. True or false? And number 4, COVID-19 vaccines are approved for the use in children younger than 16 years old at this time. True or false? Looks like people jumped right on these.
Where's that music?
DJ in my spare time.
Recall a certain magic in your eyes. It's there each time that you appear. It's so passionate it has been mesmerized.
All right, so we've attained 88% in one, 100% in one, 79% and 84% in the other. So Dr. Walks, when you're ready.
Okay, I don't see the results on my screen as yet.
Okay, there you go.
Oh, there we go. Okay. So, is it recommended that pregnant and breastfeeding women take the COVID-19 vaccine? 88% say true. COVID-19 testing is no longer necessary or needed. 100% say that is false. There are 3 licensed COVID-19 vaccines in the US. 77% read that is true. And COVID-19 vaccines are approved for use in children younger than 16 years old. 15% read that as true. So I think we need to have a little bit of discussion about this. I think that we're certainly going to have some further conversation about all of these things. But let's start with the first one. Is it recommended that pregnant and breastfeeding women get the vaccine?
So I would say yes. We actually have brand new data that just came out that shows that pregnant women develop antibodies and they pass those antibodies to their fetuses. So they respond, they're protected, and their babies are protected. So, we've been recommending, for the most part, the ACOG has been recommending that pregnant women be vaccinated even before we had any data. There had been an overwhelming response among pregnant women who were vaccinated, feeding that information back to the CDC. And we now know that it is protective and that antibodies are passed on to the fetuses. So yes.
Excellent, excellent. This question, Dr. Despani, about COVID-19 testing no longer being needed. Try to control your outrage that we're even asking that, and please let us know what you think about the folks who think that, oh, we have a vaccine now, we can just stop testing.
Yeah, that would be very deleterious to the United States and the world writ large, precisely because by continuing that testing, that's actually how we were able to identify that there were 7 variants that were operating mainly in the Midwest and the East Coast, on top of the fact that there's a New York variant, and then there was a California variant that actually came from Denmark. So yeah, I mean, Britain actually is the leader in terms of doing testing, and from that testing, that's where you deduce the viral phylogeny, or family trees and lineages. And we need to be on top of that at all times in order to stay, I wouldn't say one step ahead, but just maintain kind of the Red Queen hypothesis of every time the virus mutates, we adapt and not mutate, but we adapt and throw more of our pharmacopoeia or pharmaceutical armamentarium at the virus.
Okay, great. Thank you so much for clarifying that. And I know we talk about, I thought number 3 was a trick question. I'm paranoid. I've been in school way too long and had too many tests. 3 licensed COVID-19 vaccines in the US. So the vaccines have emergency use authorization. So you could argue they're licensed for emergency use, but they're not fully licensed. So one of you guys clear this up for us. What's really the right answer to the question?
I think it's what you just said. It's like, yes, you can use them for emergency use right now, as long as we're in a state of emergency. But, you know, when that state of emergency expires, whenever the FDA decides it expires, unless they have moved forward and gotten full licensing, they're not licensed.
Okay.
I have let me ask a question there. A lot of people have these conspiracy theories. Maybe they're right, maybe they're wrong. But under the EUA, Emergency Use Authorization, do Bill Gates and other billionaires make money off of these things? Who makes the money? Who sells? Who gets paid for emergency use authorizations?
Definitely not Bill Gates or anything. Again, like the whole thing of like, oh, it's Bill Gates and whatnot, that's a straw man argument. That the same thing like, oh, it's George Soros. So like, oh, it's the Jews. Full disclosure, I'm actually Jewish. So things like that piss me off. But yeah, no, I mean, it's the same people that we always know. And namely, it's like Big Pharma. And the whole thing is that people spend so much time, you know, painting Big Pharma as being evil that it's just like, okay, well, how do you expect to be able to respond during a pandemic? You need Big Pharma. So again, the same companies that created the vaccines, Moderna, Pfizer, and Johnson & Johnson, inter alia, because there are going to be more vaccines. Like those are the ones that are making money, right? And the whole thing is, in the case of Moderna was trying for at least a decade or so to actually create cancer vaccines before they had to pivot due to SARS coronavirus 2, and that is what allowed them to get their first mRNA-based, biologic to market. But their passion is really in making cancer vaccines. So I saw great data that Moderna released to treat head and neck cell squamous carcinoma, I believe. So yeah, I mean, like I don't understand where the conspiracy theories come from, because I mean, we already know that there are cancer vaccines. Case in point, Gardasil from, I believe that's Merck, if I'm not mistaken. I'm blanking. But Gardasil is used to treat various types of human papillomavirus. So I don't know, it's just people being Luddites, when the reality is that, do you want to live in this biblical promised land where there's no death or disease and, milk and honey flow and whatnot? Then you have to like place your faith and technology. I mean, we're eventually going to get to the point where people will be able to alter their genes, and then all the biblical prophecies you heard about people being able to like be blind and then they can see again, that's happening even now. We have gene therapies that can take a person who's born blind and give them sight again through viral gene therapy. But we'll talk about that at a later point. But yeah, don't buy into this crazy theories.
Well, I like milk and I like honey, but I like them separate. Dr. Garnes, any comments on this theory of who's making all this money? Are you making this money?
I certainly am not. But the other thing I would point out is there have been some reports in the news, but for the most part, the vaccines right now are being offered by the government. So other than charging for the actual administration of the vaccine, a lot of individuals are not having to pay for the vaccine.
Well, I have one more question. I'm just trying to clear up a few things. There are a number of physicians on this call, on this broadcast. Now, I treat patients that have COVID, etc. I'm not making any extra money. Are any of you guys getting paid extra for saying somebody has COVID than saying not? Are people being charged more money for diagnosing COVID? Let's put that to rest. Nobody, Dr. Garnes, are you being paid more money? Don't you have a new Rolls Royce?
Definitely not getting paid more money, working harder for the same.
Yeah. I mean, I'm going to definitely parlay off of what Dr. David Garnes stated. And from all of the pharmacoeconomics data, for lack of a better term, that I've seen, because the government is the buyer and everybody's receiving vaccines free, then obviously that's money from the government to the pharmaceutical companies, and obviously the pharmacy benefit managers, the PBMs, they're making a good cut out of that too. Full disclosure, I have one of my cousins is a PBM, so. But yeah, So, I mean, again, that's a whole ecosystem that, is not, I wouldn't say impenetrable to conspiracy theories and whatnot, but rather the people that have those conspiracy theories, they don't really understand how economics work. So, yeah.
So it's not the doctor, maybe Dr. Ron Bailey, psychiatrist. Are you making that money, Dr. Bailey?
We have to unmute Dr. Bailey so he can protest even your question, Dr. Maxey.
I just want to be clear. Somebody's making that money, I believe. Somebody's saying we're making the money. I don't think any of them have MDs, though. Is Dr. Gibson on? These are members of our medical advisory I'm calling on. But either they're muted or don't want to answer. But go ahead, Dr. Waltz. I just wanted to
Okay.
start put a little piss in the Wheaties.
Well, I'm gonna answer using Dr. Daly Garnes and Dr. Despani's comments. I'll answer on behalf of the rest of the doctors, unless they are also executives at Big Pharma and have some big bonuses due this year. No, this notion that practicing physicians or practicing clinical folks are making a lot of money because of COVID-19 is not accurate. And also, let me put my psychiatrist hat on for a minute. The amount of challenge that we physicians that still see patients are experiencing right now, with so much death and so much illness laid on top of whatever else folks have had before the coronavirus, COVID-19 got here. I think Dr. Daly Garnes said earlier, it's just more work. Folks are getting more work, and but Dr. Maxey, somebody is buying those new Rolls Royces. It's just not us.
Wait, I saw somebody who has a new Rolls Royce. Is Dr. Jessie Sherrod, did she get one?
Dr. Sherrod has got her hand up. If we could unmute Dr. Sherrod, I'd like to know how she got her Rolls Royce.
The Inquisition begins.
Unfortunately, Dr. Maxey, I do not have a Rolls Royce, but I think the appropriate question is, because medicine is now corporatized, we're talking about corporations, so individual physicians are not making the money. The question is, are the hospitals getting more money by putting the diagnosis of COVID-19 on the death certificate? That's the first question that I would like answered. And then there was something else that has just escaped my mind, but I'll come back to it while you're answering that.
Okay, I'm going to answer that.
Oh, I know what it is. We as taxpayers, we are actually, if the government is paying for the vaccine, that means that we're paying for the vaccine because we pay taxes, right? So you're not getting it free.
Well,
and this is a capitalistic country, so you do need to find out who's making the money.
Let me answer both of those questions, and then I'll let Dr. Waltz move on. All hospitals, as a practical matter, are underpaid. So in a billing strategy, you put the most profitable diagnosis on the descending order of the way you bill. You can bill more for pneumonia than you can for a cold. You can bill more for pyelonephritis than you can for a urinary tract infection. So that is known, and most hospitals are underpaid, and that's how that works. So COVID is no different. If you go in for a brief head injury versus neurosurgery, you're going to get paid more for the neurosurgery. So the upcoding of diagnosis is common practice, given that we created a monster called Medicare that controls pricing. And we know that back in the 2003, 2004, there was passed something called the Medicare Modernization Act, pushed by President Bush, and also the current Secretary of Health, who was the former governor of Wisconsin, that the government could not negotiate with Big Pharma to lower pharmaceutical prices. And if the medical associations such as AMA or the National Medical Association did not back that proposal, they were going to decrease the payment to physicians across the board by some 2%. So the problem is bigger than any physician or any hospital. This is your government at work. So let's go on, Dr. Waltz, to our further program.
Thank you. Thank you, Dr. Maxey. I think that before we move on to, we're going to have some end of program questions, and then I think we can move on to maybe opening to some other questions from the folks who are on. But let me say, in keeping with our overarching message today, we're looking at some of the questions folks have about COVID-19, about the way people get infected, about some of the treatments, about some of the vaccines. Those are the things that we are focused on. And the fact that the pharmaceutical companies are making a lot of money, the fact that there are some other ways that people may find to charge extra for this, that, or the other thing, the fact that Costco is selling N95 masks, all of that is useful information for us to have. At the same time, what's most important is that we haven't gotten any data to this point that tells us, no, people should not take the vaccines. We don't have any data that says that we're going to change the recommendations that have come from the pharmaceutical companies initially, then from the FDA, then from the NMA, and then from the Black Health Trust, all of whom have looked carefully at the data. And yes, there are going to be some cases where folks have an untoward effect, but I think that's true for almost everything. That's true for Motrin. That's true for baby aspirin. It's true for almost everything that we give patients, that there are going to be some people that have an untoward effect from it. For us, the concern is that we give people information that they can use and that they can use to protect their health and understand how to protect their health better. And I think that the focus is that to this point, the vaccine is what we are recommending. Folks take the vaccine. When it comes to a neighborhood near you, get in line, roll up your sleeve, and get vaccinated. And before and after you get vaccinated, all those points about mask wearing and distance and all of that, I think we want to make sure we always come back to that when we're talking about this particular, this still, we act like things have gotten a lot better. We're still having over 1,000 people a day dying from this. So it's not over. It's not time to call all your friends and have a big party. It's not over. We are in the middle of a very, very deadly pandemic. So let's go on and create some more strife with our end of program questions, please.
Okay, last but not least, number 1, COVID-19 virus was man-made, yes or true or false? Number 2, COVID-19 virus was made in China, true or false? And number 3, the COVID-19 virus was made in the US, true or false? And we'll give everyone a few moments to answer those. Numbers are still coming in. We'll give it a few more seconds. And we're at 1 minute. Simon, you want to go ahead and end the polling?
Okay.
Dr. Walsh, you can, okay.
Yes, another opportunity for us to bring some science to the answers to these questions. So number 1, COVID-19 virus was man-made. We have 26% of folks who believe that was true and 74% who believe false. COVID-19 virus was made in China. True 39%, false 61%. COVID-19 virus made in the US. 10% believe that that's true, and 90% believe that's false. This is hitting me in my trick question, Gene, again. So COVID-19 virus was man-made, and then COVID-19 virus made in China. So, Dr. Despani, was the COVID virus 19 man-made?
Yeah, I don't even know where to begin with this one, except to say like that's just categorically like false. I mean, I'll put it to you this way first, by stating like an example of like my history and like why everybody says again that my virology and coronavirus background. What I was actually trying to do from the ages of 18 to 20 was working on actually taking a cow coronavirus and basically taming it through genetic modification to turn it into something that actually treats colorectal cancers. That was actually happening around the time that my one of my paternal uncles was suffering from colorectal cancer. So I actually had like a dog in the fight. That was nigh on impossible to do because the viral titers, i.e. the number of variants I could generate, were just too low. And yeah, it's like hard to do this at like some type of scale. I mean, you could do it, but I mean you have to have like a whole bio warfare program, and then couple that with the fact that we know for a fact that this is not the first time that coronavirus has existed in nature that has infected humans. It's actually the seventh. So like you have, again, like I mentioned before, SARS coronavirus 1. So where were people in 2002 to 2003 when SARS coronavirus 1 was? Were they saying that was man-made as well? Where were people in 2012 during the Middle Eastern respiratory coronavirus? It like it had an intermediate host, which was actually the dromedary camel, and then obviously SARS coronavirus 2 is the third very pathogenic coronavirus. But I notice how I didn't mention I didn't mention like 4 other coronaviruses, and those include, like, I believe one is called OC something, like, so there are four coronaviruses that they're regular denizens, and they infect us every like flu season and whatnot. Obviously when I talk about like the flu season, when it's not just the flu, it's actually like a syndemic. I discussed that in one of my earlier talks, right, where you have adenovirus, you have coronaviruses, you have rhinoviruses, and you have influenza viruses, all vying to get in your body simultaneously. And believe it or not, there actually was a coronavirus pandemic. Again, like these are just theories and conjectures, because again, we can't go back in time and validate our hypotheses, like by traveling back in time. But there's many coronavirologists actually believe that there was a pandemic in the 1880s, I believe, that they believe was actually caused by coronavirus that eventually became a regular denizen of our virome that infects us, every like flu season or cold season or whatnot. So no, I mean, it's just like, I know people will point to like, oh yeah, like there are things known as gain of function mutations and whatnot, but we're not at the level yet with synthetic biology. We will be at some point, but we're not at the level yet where we can just like make a virus like ex nihilo, which is Latin for out of nothing, and just be like, okay, attack certain people and like, let's make an ethnic bioweapon and whatnot, because again, there's too similar to other people and whatnot. So yeah, I don't think that that's possible now. It will be later on, but by that point you'll know, because you really will have a pandemic that will, and I've mentioned this before in a private Wednesday seminar and whatnot, but you will probably have like a pandemic that will be able to wipe out 60 to 80% of the world's population, like something even like variola virus, which I think is colloquially called smallpox, that easily killed like 30 to 40% of the world's population. That did that for thousands of years. But yeah, I mean, it's interesting that somebody would try to make a a pandemic or a pathogen that, you know, would only be like, oh, it's only has like a 1 to 3% mortality rate and whatnot. So that's kind of circumspect. You'd want, you know, somebody would want to make a pandemic and whatnot. They would probably opt for, you know, like maximal destruction or whatnot. But no, it's just not, it begars belief to imagine that somebody would want to just make and could make a virus like wholesale that could be pathogenic, because once you let a virus out, like you don't know how it will actually like evolve in real time. It could become more you know, pathogenic, or it can become less pathogenic. Again, here's something that people don't know. There actually was a variant in Singapore that was, I have to watch my language, but it was terrible. It actually had like a deletion that actually made it weaker, and that's actually why Singapore was able to come out like looking like roses, at least I think for the first wave, because they had a deletion in their like SARS coronavirus variant that, you know, was not very good at infecting other people and you know, having good transmission rates, and that kind of like teed it off to the virology community that we probably will be dealing with lots of variants and whatnot. So, but that was, you know, last year. Yeah.
So Dr. Despani, there's a series of comments in the chat about the laboratory in Wuhan being a U.S. laboratory, and maybe that's where the virus was made and it escaped and then somehow made its way to Europe. Now that's a much better story than the one I got about the hibiscus tea in Africa. But can you tell us, you guys don't want to know. Dr. Despani, can you tell us, based on the information that you have, first of all, is there some credence to the fact that the US had the laboratory in Wuhan and the US made the virus to infect people and then it spread? And then answer this part also, or maybe I'll after you're done, Dr. Daly Garnes can answer this part. Why does it matter? We none of us are going to go clean up the virus in Wuhan. None of us are going to go and find the people that maybe made it. We just have to protect our communities. So help me with this concern about where it was made, and then Dr. Daly Garnes, tell us why we should care. I'm not trying to be facetious or trying to be mean. I'm just trying to say that so much of our community is dying right now, and somebody keeps telling us all of these things, and I don't know if they're a distraction or not. So I'm asking.
Yes, I mean, first off, I will say, like, I'm just so confused, because why would there be a US laboratory if we're having a geopolitical struggle with them? That doesn't make sense. That really doesn't make sense. Like China, the People's Republic of China is becoming a peer competitor. People have to worry about like actually being, you know, that they all have to speak Mandarin at some point, but I digress. Anyway, no, the whole thing is that it was, so the Chinese Communist Party had wanted to set up the Wuhan Institute of Virology, but they did not really, and the reason why they want to do that is because they wanted to have a BSL-4 laboratory, so biosafety level 4. That's where you work with very deadly pathogens, like the things that I used to scare you guys, like, Ebola virus or, variola, aka smallpox, the things that will wipe out you, your family, blah, blah, blah. Like you have to dig, like body pits to put all the dead people. Anyway, so because China is just now becoming a peer competitor with the United States, they are still trying to gain all of the technical acumen and whatnot. Ergo, they were saying, okay, we have a BSL-4 laboratory, and we do have like a lot of virologists that are going into these caves and identifying a myriad of different coronaviruses and whatnot. But we aren't so certain about our protocols to remain safe and not get our personnel infected. So US, can you kind of come in and help and whatnot? But that was, kind of a yes and no, because they wanted to have like some US oversight, but not enough that would impinge upon, whatever the CCP, wanted to do and whatnot. So it was like, okay, you can give us some technical expertise, but don't really visit like too much, I mean, it's the same thing too with like, if just using my geopolitical knowledge, the same thing too with like what's going on with Iran, right? Iran, the Islamic Republic of Iran, right, is basically saying, okay, the IAEA, you can come and do your atomic inspections, but you can only come to certain areas. It's the exact same thing.
So before Dr. Daly Garn's comments, let me throw another confounder in, Dr. Walks. I saw Dr. Cecil Motley on the phone. If you can unmute him, Simon, and I'd like him to just give a couple of brief comments on BSL-4 labs and his thoughts on how this virus might have come, even though I 150% agree with Dr. Walks, is why does it matter? We need to protect ourselves anyway, even more than ever. But Dr. Motley, are you unmuted?
He's not unmuted as yet. If we can get Dr. Motley unmuted.
Okay,
We've sent the request to ask him to unmute himself.
So since Dr. Motley may be away from his screen at the moment, Dr. Daly Garns, if you want to go ahead and then we can get back to Dr. Motley.
I guess there are two things.
Randall, did you have a question?
Okay, hold on, there he is.
Yeah,
Sorry.
I wanted your thoughts on the BSL-4 labs and the question we had on the select roundtable some months ago about thoughts on the generation of this corona virus 19, whether it came from China, whether it came from the US, and does it matter?
Okay.
I think we have to take into account that we have to protect ourselves anyway. It's out there. But just for the sake of speculation, in a couple of seconds, can you tell us your thoughts on?
Let me just tell you what I know and what I don't know. All right.
So first of all, who are you, sir?
I'm Cecil Motley. I'm a biomedical engineer and an MD PhD. And I worked with the government for some 43 years. And part of my work had to do with detecting pathogens in the battlefield or warfare agents that would kill our soldiers. So I have a pretty extensive knowledge on what the government has done in the past. Now, let me just tell you what I know. We had maybe 25 years ago, a biological warfare program in this country where we generated agents that would have very bad effects on other soldiers. The international community decided to outlaw the creation of these biological agents. And we signed into that agreement so that we would not create biological agents. The chemical warfare, as it's commonly called, would not be used. So what does the United States do? They move their biological warfare labs offshore. They put them in countries that did not sign up to that agreement. And we had people at a very high classification level working in those labs. My wife's first cousin, Dr. Malone, he was a 3-star general and he ran that program. So I have some pretty intense knowledge of that.
1 second, what happened to General Malone?
He passed away from one of the agents he was working with. Okay. He was working in San Antonio when that all happened. And we questioned why was he having these agents in San Antonio, and we never got effect. Now, my nephew Dr. Garrett Motley, worked in the laboratory in San Antonio also. He also died from an unknown cause. They told us that they found him in an aircraft hangar with a timing device in his lap. That's the only information they would give the family. But look, the bottom line is this country still works in biological warfare. They just find ways around it. All right, that being said, their main thrust is genetic engineering of various microorganisms. And they genetically engineer these organisms to do what they want these organisms to do. I don't know if—
Dr. Motley, I don't want to go too far into this. I just wanted to let there be a sense of awareness that there's potentially more to this puzzle than we know, or that is the scope of this call. The scope of this call is to provide protection for our families and our communities. And it even underscores even more that you got to take care of your body, your immunity, your health, the way you eat. That's the most important thing that we can say on this call. But let's go back to Dr. Walsh was recognizing Dr. Daly Garnes on the larger question.
So to get back to the question on does it matter? So I think there are two ways to look at it. You know, from a day-to-day perspective, virus is out there, we have to deal in the reality that we have right now. And, you know, one of the things that it reminds me of, although I was there in a much younger capacity, was when HIV emerged, that there was a lot of time spent about, you know, where it emerged from, the population in which it emerged. But at the end of the day, our community was disproportionately affected. And until we got to a point that we were dealing with the reality that our community was disproportionately affected, we weren't making any headway. And so, you know, regardless of where it came from, we have to deal with the fact that our community is disproportionately affected. Now, there is a comment in the chat that's saying that the source matters for future management. So, you know, I think it determines, like, you know, when you're thinking future management from a public health perspective, which gets back to what has been mentioned by both, you know, individuals that have spoken to this question before me, that there are ongoing programs in addition to what we may be doing, which I have no knowledge of, but there are ongoing programs to detect what other people may be doing. And so, you know, in terms of, you know, whether things are being created and emerging, you know, there are mechanisms to try to detect that. You know, in terms of something that naturally emerges, we know that there is this One Health initiative that's looking at, you know, the closer interaction between humans and animals and how that is resulting in the development of bacteria that are more resistant, how that's resulting in emergence of new pathogens. You know, so both of those things are ongoing efforts, you know, regardless of what the source is.
Dr. Daly Garnes, that is exactly the point. One quick comment that I'll make, and maybe you and Dr. Despani can respond to this. So much of us looking to the future is about making sure that the people who we vote into office are thinking the thoughts that we're thinking and are looking to the future in the same way we're looking at it. What COVID-19 has done is point out a lot of disparity and a lack of equity in our communities, and it's ongoing. The numbers we quoted earlier today about the percentage of us being vaccinated, you cannot just say, oh, well, there's hesitancy and that accounts for it. That's not accurate. There's no data to say that hesitancy alone accounts for what we are seeing in our communities. And so we need to make sure that we are active. We don't just wait until there's a pandemic to get upset and wonder what happened. Dr. Maxey's point about, you know, we would like to present the coronavirus with a healthy set of lungs and a great immune system. Every time it tries to get one of us, we want to be as healthy and as prepared as possible, while our elected officials are putting programs and projects in place to keep all of us healthy. So I think there's this need for us to really focus on what is it that we're doing. So as we're getting into the 440 timeframe, Dr. Daly-Garns, can you kind of sum up for us, what are your thoughts? How do we as individual practitioners say to our patients, from my public health hat, public health is about getting people to do something, right? So what do we say to our people? We want you to do this. We're in the middle of a pandemic. Here's what we want you to do.
I mean, I think one of the things, it's important to have a conversation with your patients. Don't just say, you know, the answer is that you need to get the vaccine and not be willing to have that conversation. You know, let them ask their questions. When I have patients who tell me, you know, they have or have not been vaccinated, and, you know, I ask them, are you planning to get vaccinated? You know, what are your concerns if they have concerns about the vaccination? Is it that you just haven't had the opportunity yet and you're waiting for someone to offer it to you? Or do you have questions about the vaccine? And if I'm in a position to answer those questions, or even if I don't know the answer at that time, if I can look into and give them more information that can help them make that decision. You know, one of the things that they talk about vaccine hesitancy in general, because this is something as pediatricians we deal with often, is, you know, one, assessing where your patient is on the spectrum of vaccine hesitancy. So, you know, are they in a place where, you know, it doesn't matter what you tell them, they're not going to get the vaccine? Or are they in a place where they're definitely going to get the vaccine? Or are they somewhere in between where they just need more information? And a lot of patients are in a place where if their clinician, their personal physician or clinician that they have a relationship with is recommending it, that they're going to take that advice strongly into account. And so I think it's, you know, us not, you know, denouncing people for having concerns. They're legitimate concerns. But really, you know, educating them, having open and honest conversations, acknowledging those concerns. I think that's the way. And then, you know, really opening the access, because I can tell you all day long that I recommend you get the vaccine. But if you're calling and you can't get it, you can't get an appointment, you don't have internet access, and that's the only way you can schedule an appointment, you know, what's the point?
Well said. Well said. So we have a lot of logistical opportunities to improve things in our community. I think I see Dr. Ron Bailey is on, and Dr. Maxey had reached out for Dr. Bailey a little while ago. Dr. Maxey, do you want to revisit your question with Dr. Bailey?
Yeah, Dr. Bailey, how are you, sir?
Fine.
Good. Got your note. I was originally calling on a semi-humorous note to find out if you were making all that coronavirus money, because people say that MDs are making more money because of corona. But from a serious standpoint, and to follow up on what Dr. Daly-Garns and Dr. Walks were speaking about, from the perspective of a psychiatrist and public health proponent, how can we more effectively convince our communities of color and our families that they need to heed the word of being healthy, strong, have a strong immunity, eat correctly? What can we do in terms of making that more realistic? We obviously are missing the mark, that people think that all they have to do is pray and everything's going to be all right. What can we do for our communities to protect themselves?
Two quick answers. One that you didn't ask me, and one that you did. The one that you didn't ask me that I wanted to jump in earlier on is the issue about money is tangible. At Kedron Hospital, we have a multi-million-dollar ask-in for the up to now 3,000 vaccinations that we're actually giving each day. That could go as high as $4 or $5 million, because the reality is that the numbers are growing pretty exponentially. In fact, with the mayor at Kedron Hospital on Friday. So I think that for those who are listening, you're right to make the point that there's a fair amount of pot of gold at the end of the rainbow for groups, not just companies, but also hospitals that are very involved in this game. And along the line with the other things you said, I think on this program you have each week, you and Ivan and the group, African-American run settings need to be in the midst of that process to treat it fairly, every bit as well. Now, to answer your second question, I think that there are huge issues, I think, for our psychiatric concerns and mental health. I'll give you three of them. I think first, the reality is, as someone said some point before, when there's a small problem in one community, there's a huge problem in ours. Issues about viruses and having pneumonia. And that analogy is true, I think, here as well. We're already seeing an uptick in psychiatric admissions, worsening of paranoia and fearfulness. I'm on call this weekend, and I admitted 9 people yesterday. We generally average here between, say, 2 and 4 admissions on a weekend. So clearly, we can feel palpably the change in the level of fragility many of our patients have on the inpatient psychiatric side. And clearly, we should be mindful of that in our community. And professionals, I think, should be very sensitive to addressing these increasing demands in that sphere. The other issue is also true for many persons who have what I call subsyndromal functional problems psychiatrically. Those with depression or anxiety will just take maybe a pill for an SSRI for depression or maybe an anxiety medicine regularly. We might see many of those kind of go over the threshold, we call it, going forward, and they need bigger care, more involved investment, up to and including stronger medication management or even hospitalization. I think that to prevent that, we should be very proactive in our approach. I love the issue of education that you have on this program regularly. I wish that all of my patients and staff and their families could actually listen to it every Sunday. I, like you, I learn something every week. I also think, though, that it points out the gravity and the seriousness, I think, as both your professional speakers have stated today, of this concern. And it's likely to be one that I think goes on for an extended period of time. So in the other comments, I think that you've had today also, I think, address the fact that new problems are likely to be determined, maybe not developed, but better assessed in this regard. And we should be, I think, at the front of the line, acknowledging them, I think, in ethnic minority populations, I think, going forward. My final point is it's hard to have any discussion in this day and age and not discuss issues regarding hatred and bias and how it leads to further incapacitation of some groups, whether it's hatred against Asians, ongoing problems of bias against other ethnic minority groups. We're seeing a fair amount of that as well. A lot of antipathy where we are for whether or not we're giving a vaccine fairly and equitably to particular groups, and or whether or not we're receiving enough vaccine, from the city and how it's actually being distributed. So keeping our eye, I think, on those issues going forward are going to be key, and pressing all of the buttons, the political buttons and otherwise, to ensure that I think, again, I mentioned fair and equitable distribution of vaccine to sites like ours and to patients in our community, I think are going to remain very, very important.
Well, thank you very much. If I have your permission, Dr. Walters, I'd like to bring one other person to the forefront and just ask him how he created such a positive effect to save lives, decrease morbidity and mortality in Buffalo, New York, in that cold sub-zero area. How did you do that, Pastor Pointer, and what points, no pun intended, can we take from some of the things that you did in a brief statement from Buffalo?
Well, the first thing we did was we put testing everywhere. I mean, we put testing in the neighborhood where people didn't have to travel across the city to get tested. We knew that getting on public transportation was a community risk. So we put testing right in the neighborhoods where we already knew that 42% of people didn't own transportation. So we put the testing where all they had to do is walk around the corner. Buffalo is a city of just over 250,000 people, but it's a city that's small geographically. It's only 42 square miles. So we saturated neighborhoods with testing. That was the very first thing we did. And then we started calling people on the phone and having health literacy education conversations with them about what coronavirus was, what they needed to do to protect themselves, what the current science was at that moment. And as science changed, our conversations changed. We gave people the truth, working with the Erie County Department of Health and the virologists at the Jacobs School of Medicine and Biomedical Sciences. We were able to tell people what we knew. And we were not looking at China. we were looking at Italy, Spain, France, and Germany, because we knew that we've got a large American hyphenated Italian community in this city. And so we were likely to have folks traveling back and forth from Italy while things were going haywire in Bologna. So we just simply gave people the honest information, put the resources necessary to them. And when we went to New York Pause, we delivered food to people, no contact in their homes. We delivered masks and gloves, hand sanitizer, Clorox, and Lysol to their homes.
So it
and
sounds
then
like
delivered instructions on how to use it to protect themselves.
So it sounds like you did the basics. You taught people how to stay clean, to eat right, to be fed, to work together. Not necessarily high-tech stuff, just common sense stuff. And my observation is we lack a lot of common sense in this country, that everybody wants to be free, everybody wants to celebrate spring break and wear no mask. And it's the basics that I think we need to bring to the table. Good nutrition, good hygiene. It's just common sense and working together. That's what I hear.
Yeah, 25 churches spread across the region, set up call centers. I have 91 employees calling people 8 hours a day. So we actually made over 600,000 phone calls between May and January. We deliver food to 1,100 families a week in the region. I mean, just the basics, and people have lots of questions. A couple of weeks ago, we stood up a call center to enroll people for the vaccination, and in 12 hours, we enrolled over 1,200 people to get the vaccine. What we found was people wanted to know, what is this vaccine? How was it developed? Who developed it? What will it do in my body? So we answered their questions based on what we know of the science.
Maybe Dr. Walks, we can put together a special effort in addition to this education platform, that we can practically make some of this stuff work and save some lives in our communities, so we can live to fight another day, whether this virus was made in Wuhan or in San Antonio. I don't care where it was made, it's against us, and we have to be able to fight it. So you need to help lead us and tell us how to do those things. I know we're getting close to that hour where we have to say goodbye for our broadcast, but where should we go from here in the few minutes we have left? And I, at the end, want to leave room for a couple of announcements, Dr. Walks.
So Dr. Maxey, I really appreciate, always appreciate hearing from Reverend Pointer, hearing from my good friend, Dr. Bailey. Let me highlight one thing Reverend Pointer said. Reverend Pointer talked about understanding the community that he was serving. He talked about understanding that the infections may come from a certain part of Europe because he knew about his community. He also stressed the fact that there were 25 churches. And so that, when I hear church and I hear healthcare, I get excited, because it means that we doctors and the pastors are cross-pollinating, that we're knowing about each other. And that's true community. So I get excited about those things. I think, Dr. Maxey, the last thing I'll say is we had several people in the chat who didn't specifically say they took issue with my flippant handling of, I don't care where it came from. I really wasn't trying to be flippant. I really was trying to focus on the priority. But let me say, it is important that we understand everything going around us in our world, because guess where it's going to come first? It's going to hit us very hard. So I respect and actually want to acknowledge all the comments in the chat about, we do need to understand where it came from. We do need to understand how it got here. And Reverend Pointer touched on that by talking about that specific part of Europe that interacted with his community. So all of it matters. It matters that we're here and that we care. And Dr. Maxey, it matters that you have been able to bring us together in this kind of a format where these things can be made clear. So I want to toss the last couple of minutes, Dr. Maxey, back to you. You said you had some announcements. Next Sunday is Easter, but it's still Sunday. So what are we doing?
We will have our program as usual. It may be a bit abbreviated. Maybe it'll be an hour and a half as opposed to 2 hours, but we will be here. And I think we are doing the work of God. And we may have some special guests because it is Easter. And we will continue on answering people's questions about the virus, about the vaccines, about health disparities. So we will be here as usual, and we will celebrate Easter Sunday with those of you who join us, and we hope to have a biggest audience as possible. The other thing that's clear, because of this program and people having, and Dr. Jordan brought this up, that many of our people use urgent care centers and emergency rooms as their primary care. And therefore, they don't have the relationships of medical advice that's good for them. So we created Biometric Second Opinion Expert. And many of our physicians and friends have joined those panels that we can provide you with not only medical advice about COVID-19, about vaccines, but about all aspects of your medical, physical, mental, and spiritual health. And we've stood up a panel for that, and we now, at last count, have going over 100 select physicians from across the country, a large number of which are from our community and look like us, are members of the National Medical Association. But of necessity, we've had to go out and vet doctors who may not just look like us, but who think like us and practice like us. So they're not all Black, but they're with us and they're our brothers and sisters. And I've had 2 personal consults within my family that have worked out very good. You can go to that website, which is biometrics.second, spell out the word, opinionexpert.com, and read the directions, and our assistant can help you through that. If you have need, I encourage you to use that. We also, I believe, have our website is greatly expanded as of today with resources that you can use in terms of articles, opinions. We're going to be doing podcasts. And in the month of May, we're going to honor some of our venerated mothers who have lived to significant age and have wisdom that they want to impart to us. I know Dr. David Brewer's mom is one. Dr. Waltz, I may call your mom. You don't know I know her, do you? But we're going to have a few of these venerated Black women heroes speak to us and advise us on going forward. Many of us wouldn't be what we are or what we think we are without these great women. And we have another number of programs coming up. Dr. Bailey's coming back. The Cobb Institute is coming to bring us a program. And we have Arnie Joseph bringing us programs and a number of people, Dr. Sherrod. So we'll keep the ball rolling. And we are going to be celebrating our 1st anniversary in the next few weeks of Black Health Trust. So I'd like to thank Dr. Despani, who's been our rating expert week after week. And I thank you for working through your 2nd vaccine to come to us, despite a 3-mile walk. And Dr. Janine Daly Garnes, we appreciate you coming with your expertise again and again, and our other panel members who are with us a lot. We appreciate you all. And are there any final questions or notes of interest in the chat box, Michelle?
I think just one general one for the average person. Do you have any feeling either way about the Pfizer, Moderna, or Johnson & Johnson vaccine?
Dr. Janine Daly Garnes, hit it.
So I will go back to a comment that was made earlier. The best vaccine is the one that you can get. So
Great
I
answer.
really can get it.
Great answer.
All right. Well,
All
that's
right.
good. And
I think that's it.
I appreciate our colleague, Dr. Ivan Walks. I certainly appreciate you and love you. And Dr. Neighbor Stevens, a special hello to you. We miss you.
Yes.
Drive safely. Special thanks to Simon, our tech. Full disclosure, he's an expert friend of mine, and he may even be related to me in some way. But thank you, Simon and Skylar, for creating our flyers and artwork. And Yukini Stevens, who I call Zucchini, for being our virtual assistant. And thank you, Michelle, for being our hostess with the mostest on our advisory committee, our steering committee, and our special guest, Dr. Pointer. And also I point out the not doctor, but John Sudukas has been appointed as special consultant to the chair, and he's been bringing us our celebrity group. Did anybody see the NAACP Image Awards the other night? Look forward to BHC doing something similar in the fall. Thank you so much, Dr. Walks. Is Brenda Lieger available?
She did not make it yet from church, so she said to tell you she sends her love, but she won't be here.
So is her daughter gonna sing us a song? Don't
Nope.
choke.
Nope. Farewell, everyone. Stay positive, stay safe, keep your immune system strong, exercise, and get yourself vaccinated if you haven't done so already. God bless you all.
Thank you, Dr. Walks, Dr.
Take care.
Garnes,
Bye.
and Dr. Despani.
Thank you.
Take care.
Hey, have a great day.